Thank you. So we're going to talk a little bit about the management of polycythemia vera in the context of recent developments, both in how we prognosticate patients who have PV, as well as developments in new treatments for patients with PV. So we'll start with a case presentation. We have a 45-year-old male who presents for referral. He has no significant past medical history, but he was referred for erythrocytosis noted on a routine CBC. On evaluation, he has symptoms of headache, dyspnea on exertion, and pruritus. His examination is really without evidence of organomegaly and is otherwise largely unremarkable. He has no history of thromboembolic disease. Review of his blood counts at the time of initial evaluation demonstrated normal white count, hemoglobin of 18, above reference range, hematocrit of 54%, normal platelet count, serum EPO of 1.8, and positive for the JAK2 V617F mutation. He underwent a bone marrow examination, which was deemed to be most consistent with polycythemia vera. Patient was started on aspirin and therapeutic phlebotomy. After his initial phlebotomy, his requirement was about once per month. His symptoms of headache and dyspnea on exertion resolved, and he continued to have mild pruritus, which wasn't particularly troublesome to him. However, over the next 3 years, he developed worsening pruritus, as well as marked fatigue and low-grade fevers that occurred several times a week, and infectious workup was negative. Fevers were deemed to be secondary to his PV. He began to develop mild splenomegaly with a spleen tip palpable on examination, but wasn't quite symptomatic. He had no leukocytosis, a mild thrombocytosis of about 700,000, but his phlebotomy requirement was unchanged. What is the optimal management of the patient at this point? And I think this is something we're going to discuss and debate in the next few minutes or so. So, briefly, the diagnostic criteria for PV by the WHO include currently an elevated hemoglobin, and this is something that is the subject of modification. Whereas it was previously 18.5 in men, now likely to be reduced to 16.5, and 16.5 or greater in women, now down to 16. The presence of the JAK2 mutation remains constant, but in the proposed new criteria, bone marrow examination is mandatory for diagnosis. Minor criteria continue to include a decrease in the serum EPO level, and the new revised criteria would require 3 of the major criteria, or the first 2 major criteria, and 1 minor criteria. So what are the clinical considerations in the diagnosis and management of patients with PV? Well, we know about the erythrocytosis as a primary manifestation, but in some cases this can be accompanied by leukocytosis as well as a thrombocytosis, either during the course of the disease or as a secondary manifestation of iron deficiency due to phlebotomy. Patients may or may not have splenomegaly. But we worry about the cardiovascular complications due to thrombosis or to hemorrhage, and these can be arterial events or venous events, and thrombosis affecting unusual locations such as the splenic circulation. Symptoms certainly can include a variety of things, including pruritus, fatigue, shortness of breath, and dizziness, as well as symptoms that are related to splenomegaly. And of course, there is the potential for disease progression to MF or to AML. So what do we know about the actual natural history of PV? Well, from retrospective observational studies, we know that the overall survival of patients with PV is impaired. It is significantly reduced, with a median survival reported of approximately 20 years. The survival is inferior to the general population. The 15-year leukemia risk is about 7%, and the 15-year risk of myelofibrosis about 6%. But the risk of thrombosis is 27% at 15 years. And this is the most marked finding in terms of the natural history of PV, and this has largely driven risk stratification and management of patients with PV. And indeed, our modern risk stratification places patients into low-risk categories if they're under the age of 60 and have not had a history of thrombosis and have a platelet count less than 1.5 million, as well as not having cardiovascular risk factors. But high-risk patients are those over the age of 60 or who have had a previous thrombosis. And I think one of the questions we have to think about and ask ourselves is that sufficient in terms of risk stratification for these patients, considering that thrombosis, although it is the most predominant thing we worry about, is that the only thing we should be worrying about? So therapy and goals. The goals of therapy largely, again, are to decrease the risk of thrombotic events, but also to reduce symptom burden. What are the therapeutic modalities available to us? Well, therapeutic phlebotomy, cytoreductive therapies such as hydroxyurea, interferon, and most recently ruxolitinib, and antithrombotic modalities such as aspirin and, quite importantly, lifestyle modification. So the use of aspirin at low doses has demonstrated a beneficial effect in patients with PV. This is a study from 2004 that demonstrated the use of aspirin at a dose of 100 milligrams significantly reduced the risk of thrombotic events in patients. Subsequent studies have had various results in terms of using higher doses, but in general, there has been an increased incidence of bleeding events at higher doses. So we certainly recommend lower doses of aspirin. What about therapeutic phlebotomy and what's the goal? Well, interestingly, this was a question that was answered relatively recently, where patients were randomized to a goal of either a hematocrit of less than 45% or 45 to 50%. The primary outcome that was examined here was the risk of cardiovascular events, and importantly, patients who were randomized to the low hematocrit control group, less than 45%, had a significantly reduced incidence of cardiovascular events. And this has led to the goal of 45% for phlebotomy being the current standard. So we've talked about the mainstays of therapy, which are really for what we deem to be low-risk patients by the criteria that I've shown you before, therapeutic phlebotomy and aspirin. But when do we institute cytoreductive therapy? What are the true indications? Well, there's a couple of indications that have been advocated for in consensus. Some of this is, of course, based on the risk of thrombotic events. So we think that, again, patients over the age of 60 are at high risk for thrombosis, and so those are patients who we would consider for cytoreductive therapy. Frequent phlebotomy or poor tolerance to phlebotomy, symptomatic or progressive splenomegaly, severe disease-related symptoms, a platelet count greater than 1.5 million, or a progressive leukocytosis. So hydroxyurea is often used as the first-line cytoreductive agent in the United States. And we know from several older studies that the risk of thrombosis is about 9% on hydroxyurea compared to about 23% with phlebotomy. And hydroxyurea certainly can be useful to control myeloproliferation and organomegaly to an extent. The incidence of acute leukemia, again, a controversial topic with the use of hydroxyurea, was about 6% after 8.6 years compared with previous studies showing 1.5% with phlebotomy, but this was not statistically significant. And more recent data from Teferi and colleagues did not reveal an association between hydroxyurea and leukemia. What about interferon? So a phase 2 study by Kilajian and colleagues several years ago has demonstrated the efficacy of pegylated interferon in PV, and this is something that we had talked about a bit yesterday. But if we look at complete response in the solid line versus partial response, we see that over time there is an increase in patients who have a hematologic complete response to therapy. And I think that's an important point to remember, is that it does take some duration of time to see an effect with interferon often. We certainly worry about toxicity with interferon, and if we look at the discontinuation rate over time, there is certainly an increase in discontinuation secondary to toxicity and other factors as well, but it is not an insignificant amount of patients who need to discontinue interferon due to toxicity. Another important point is that the JAK2 allele burden has been shown to be markedly decreased in patients with PV, and in this example we see that we start out in this cohort of patients at greater than 40%, but at 36 months or so, it's roughly between 5 and 7%. And so this is one of the landmarks that we start to think about in future trials and also with our current therapies. Do we really reduce the allele burden over time? I think it's also important to point out a subsequent finding in that patients with JAK2 and TET2 mutations, which is not an infrequent occurrence in patients with PV, we sometimes observe that the TET2 clone is not affected by interferon. And so this really does raise the question, is looking at the allele burden of a single gene relevant or the most important endpoint to think about on a molecular level with the use of any of these drugs? Now, what are the challenges that still remain in regards to the tools that we have had in the past? I think one of the most important things to consider is the symptom burden in patients. Now, certainly the symptoms in patients with PV have been well talked about previously, but Dr. Mason and colleagues have done a tremendous amount of work in developing the symptom assessment tools so that this can be adequately measured in patients in a prospective fashion. And if we think about the most common complaints or symptoms that patients with PV have, among the most common are certainly fatigue, but also symptoms such as insomnia, itching, of course, bone pain, and abdominal pain. And so as you can see from this, there is quite a spectrum of different symptom complaints that patients can have at a really marked percentage of patients, I would say. Now, Dr. Mason and colleagues had put together this study where they clustered the symptom profiles of a series of PV patients, and these ranged from patients who had relatively low frequencies of the symptoms that are assessed on the total symptom score to patients who had had very high symptom levels. And so on the low end, these include clusters of patients who just had fatigue. As we sort of progress up the scale of severity, patients with fatigue, insomnia, and sexual dysfunction, patients with fatigue and marked pruritus, patients with high fatigue, insomnia, early satiety, and abdominal pain, and patients finally who had high levels of all of the items that are on the list of the symptom assessment form. And so we see that there is a spectrum in terms of the cluster of symptoms that a patient with PV can have. So how do the symptoms relate to our current prognostication schemes? So if we think about prognosis per the most recent criteria by Teferi and colleagues, which are age, a history of thrombosis, and leukocytosis, what things correlate with symptoms? Well, a couple of things. Number one, laboratory abnormalities, usually leukocytosis, the spleen size, or the presence of a palpable spleen. These all correlate with symptoms in patients. But what's very interesting, and I think very important, is that if we look at the risk score itself, it does not correlate with the symptom clusters, and it does not associate with the overall risk score. And so what this tells us is that we have to think about factors beyond thrombotic risk when we are trying to stratify a patient and to try to select what is the most appropriate treatment for them. We also are faced with the problem of therapeutic resistance or intolerance. So with regard to hydroxyurea, we know that about 20 to 25% of patients develop significant side effects on hydrea, and these can include leg ulcers, myelosuppression, hyperpigmentation, fever, and to some degree alopecia. Patients may fail to achieve target response to hydrea therapy, and patients may have resistance or intolerance to hydrea that's associated with a worsening symptom burden, a worsening risk of disease transformation to AML or MF, and in fact, a reduced survival. Phlebotomy itself certainly can have some side effects, which can be fatigue and cognitive impairment, and to some degree increased pulmonary artery pressure, largely owing to iron deficiency. And so these have actually been formalized into ELN criteria for the resistance of hydroxyurea, or resistance or intolerance to hydroxyurea, rather. So these findings, in part, as well as the marked symptom improvement that had been noted in the COMFORT studies with ruxolitinib, led to the RESPONSE trial, which looked at patients who were deemed to be resistant or intolerant to hydroxyurea and had an ongoing phlebotomy required, as well as splenomegaly. Patients were randomized to ruxolitinib or to a best available therapy, which included hydrea, interferon, as well as other modalities. Patients were allowed to cross over. The primary endpoint was the percent of patients who achieved both hematocrit control and spleen response at week 32. So looking at the composite results, there was a marked decrease and a statistically significant decrease in the patients who received ruxolitinib versus standard therapy in terms of achieving that composite endpoint. If we break it down and look at hematocrit control, 60% of patients on the ruxolitinib arm versus 19.6% of patients on the BAT arm achieved that endpoint. And in terms of spleen response, again, a statistically significant improvement in terms of patients who received ruxolitinib. The proportion of patients who remained on study was largely stable throughout the duration of the study to the point that it was reported. And sorry, that'll be the next slide. But the symptom assessment form was also evaluated in these patients. And this pertains largely to the points that we were just talking about. We do certainly see symptom improvement in patients who received ruxolitinib versus those who had received standard therapies. And so if we look at the composite score from the symptom assessment form, there was a marked improvement in patients who received ruxolitinib. Then patients who were having cytokine predominant symptoms, as well as hyperviscosity symptoms, as well as the splenomegaly cluster of symptoms, all saw marked improvements in their symptoms related to these specific clusters. Finally, overall therapy was well tolerated. The only thing to make note of is that there was an increase in viral infections noted in patients on the ruxolitinib arm, and I think that's something that warrants further study. So with all of this in mind, and to conclude and to bridge us to the debate, what we know currently is that the goals of therapy in PV largely have been aimed at reduction of thrombotic risk. And low-risk patients thus far have been managed with modification of cardiovascular factors, phlebotomy with a target of less than 45% hematocrit, and antiplatelets and anticoagulation therapies. We know that cytoreductive therapies are reserved thus far for patients who are refractory to or intolerant of phlebotomy, as well as those who are at a high thrombotic risk. But I would make the argument, based on all of this, that the order of cytoreductive therapies in the first line is an open question. And I think that is true for all of the three major cytoreductive therapies we currently have available to us. Second, the symptom burden is an important consideration in the management of patients with PV. And the other very important point is it does not seem to correlate with the risk score, indicating that we need to consider this when we make our treatment decisions. We know that hydroxyurea certainly has efficacy, but it does have limitations in controlling symptoms, and it does certainly have important side effects that may limit its utility. And we know that ruxolitinib is now approved for patients who are resistant or intolerant to hydroxyurea. But the question remains, which patients are best suited for which therapy? And with that, I think we will begin the debate.